Hi, everyone. My name is Casillas. I'm going to talk a little bit about BP Reach, which is project number 1 of UC END Disparities. The title of the project, BP Reach, it stands for Blood Pressure Disparities Reduction, Equity, and Access among Safety Net Patients with Cardiovascular Health Risk, alongside Amy Towfighi at LA County, USC. I, Alejandra Casillas at UCLA, help to lead the study. So it's great to be here today to talk about our work and what we plan to do. So just to give you some background as to why we are conducting this study, disparities in blood pressure control really call for our action. We know that high blood pressure is the #1 risk factor for heart disease and stroke, and that non-white adults are more likely to have high blood pressure or hypertension versus white adults, and that Black and Latino individuals are less likely than non-Latino white individuals to achieve complete blood pressure control over the course of their lifetime. We know that there are also race and ethnic inequities in simply awareness of the need to control blood pressure, and then after that, having access to treatment equitably, and then after that, even control rates despite adequate treatment. We also know that amongst those patients with prior stroke or prior heart attack, non-Mexican, Latino, and Black patients are more than 3 times more likely to have poorly controlled blood pressure. And we know that factors having to do with the social determinants of health, like socioeconomic status, SES, limited English proficiency, underinsurance, these all play into those factors as to why our patients are facing these disparities in blood pressure control. To give you some background as to why we're focusing on hypertension in the Los Angeles County Department of Health Services, DHS, which is the safety net for Los Angeles, I just want to put this into context. Los Angeles County is composed of 10 million residents across 4,000 square miles, where 35% of people speak a language other than English at home, and over half of the adults in LA County are born outside the United States. Nearly 20% or 18% have incomes less than the federal poverty level, and we have high rates in Los Angeles County of preventable chronic health conditions, 25% with hypertension, 21% are obese, 9% with diabetes, and 8% with heart disease. And for this county, the Department of Health Services, LA County DHS, serves LA's most at-risk residents. LA County DHS is the 2nd largest municipal health system in the United States, one of the largest safety net systems in the country, with an integrated system of 4 hospitals, 26 health centers in the community, and over 70 clinics affiliated with it. They see nearly 700,000 unique patients every year, and they serve an overwhelmingly diverse population in terms of race, ethnicity, and our most socioeconomically underserved patients, where 70% are eligible for Medicaid and 15% are unhoused. The specific aims of BP Reach are threefold. Number 1, our aim is to design a multi-level, culturally and linguistically tailored intervention for reducing blood pressure among multiracial, multi-ethnic individuals with a history of stroke or heart attack in LA County DHS or the Los Angeles Safety Net. And we are focusing on folks with a history of stroke or heart attack because they are the most at-risk individuals of having a repeat event if blood pressure control is not achieved. Number 2, we're going to test the impact of this complex intervention on systolic blood pressure control for individuals with a history of stroke or MI in a randomized control trial in the Los Angeles County Department of Health Services. And our primary outcome will be the change in systolic blood pressure at 12 months. And then number 3, we will determine the effect of multiple mediators that are part of our intervention on the primary outcome of systolic blood pressure. So I want to give you some context to our study. We, as PIs and as project members in the study, have a history of partnerships and embedded research at LA County DHS that has really led to this intervention trial. We have a history of being embedded in LA County DHS doing research, particularly with our stroke neurologist, Dr. Towfighi, in my work in digital health equity and the safety net, where we have worked to engage key stakeholders and help to align interventions and research with clinical operations. And we have prior academic, health services, and community partners from 3 previous RCTs of novel interventions to improve post-stroke blood pressure control, and also an ongoing primary prevention trial of hypertension in the LA County Department of Health Services, working with Dr. Brown's Decipher project. And so we are really building upon our experience testing multi-level complex interventions to improve blood pressure control amongst the most vulnerable patients with cardiovascular risk in the Los Angeles safety net. So just to give you a sense of our study design for BP REACH, it is a randomized controlled trial set in the Los Angeles County Department of Health Services in the inpatient setting, and also within cardiology and neurology outpatient clinics at the 4 primary LA County DHS hospitals. Our participants, we seek to recruit 1,000 patients with a history of MI or stroke who are English or Spanish speaking. And our recruitment strategy, we will have RAs review inpatient admissions and upcoming cardiology and neurology clinics at each site for our inclusion and exclusion criteria. And we are working with cardiologists and neurologists at each of the 4 sites to help us with recruitment. We will have 1-to-1 randomization stratified by site and medical history. So we have equal patients with stroke and MI, stratifying again across language as well. And then the meat of the study obviously is our novel intervention, which is multi-tiered, multiple components, where our intervention is composed of a pharmacist component really leading blood pressure medication management, sort of augmenting standard of care. We know that primary care providers are really busy with their patients, trying to take care of many issues, especially in the safety net. So really adding this level of pharmacist-led blood pressure management is hoping to offset some of the burden from the primary care provider and hopefully improve the care of the patient by making it so that they're on the right medications for blood pressure control and adhering to them. And then the other component is a community health worker-led intervention. Part of the intervention where we will have the community health worker lead motivational interviewing, use culturally tailored education on vascular risk factors to help patients learn how they can prevent a repeat stroke or a repeat heart attack, and really also a focus on self-management, including diet and lifestyle factors, education on this, and also a novel focus on telehealth and digital readiness as part of self-management for health. So also focusing on educating patients on using their patient portal, equipping patients with home blood pressure monitors and helping them learn how to use those. And then also helping them use a digital app that we have developed for the intervention to help them really focus on their diet and lifestyle modifications. Just to mention our research study evaluation, like I had said, the primary outcome is a change in systolic blood pressure at 12 months. We'll also look at secondary outcomes such as Life Simple 7 score, overall blood pressure control, whether patients simply get to goal, and then changes in BMI, changes in hemoglobin A1C, and total cholesterol. The timeline for the study, so patients basically will be in the study for a year. So we will have study evaluation visits at baseline, at 3 months, and at 12 months with an RA. But I should say that BP REACH overall will last a total of 5 years. Patients will receive, in terms of monetary compensation, $30 at baseline and at 3 months, and then $50 at 12 months to help keep them in the study. And like I mentioned as well, 1,000 patients we seek to recruit to ensure 940 patients stay in the study, or 470 per arm, control versus intervention. And this is assuming 20% attrition and then having 80% power to detect a change of 2.4 millimeters of mercury in systolic blood pressure. Other evaluation components of interest will be sort of trying to figure out possible mechanisms of change in the most significant portions of our intervention. So we'll be looking at, the different facets of the intervention, the pharmacist component, what the community health workers do, what happens with the blood pressure monitors, looking at the use of the educational materials and seeing whether any of these have any sort of more strong impact on systolic blood pressure controls. I just want to mention a very important note about, what is different about this study intervention, and just highlighting the fact that, this whole notion of having pharmacist-led blood pressure management following evidence-based protocols, we've seen that this has been effective. In the literature, pharmacists are trusted entities in healthcare. People see them often, right? So they feel close to them. And we also know that pharmacists also tend to be a more diverse workforce, which coincides with the diversity of our safety net. So it's really great to have this component represented in this intervention. And so the pharmacist will work to initiate medications and then titrate medications to goal blood pressure. And as well, because of this trust, they will be able to address some health literacy with the patients and also work on medication literacy and medication adherence. Our community health workers will obviously be helping patients improve, improve their risk profile for preventing repeat MI or stroke and working on those vascular risk factors, but they'll also be working to overall increase healthcare access and identify needs for these patients in terms of their needs within the healthcare system. So apart from all the motivation and education content on risk factors for stroke and MI, CHWs also will be screening for social determinants of health. They'll be referring participants to resources in the community and enhancing health literacy and management skills that go beyond just simply, improving blood pressure control, I would say. And then I think one of the really cool parts about this intervention is also within the community health worker component, we're going to be championing telehealth, which we've seen is very important during the times of COVID-19, how important telehealth has been to expanding care. So we'll be able to expand this type of care for vulnerable populations and address digital divide barriers. So we'll be doing some basic digital literacy coaching on the Los Angeles County Department of Health Services patient portal. Our patients in the intervention will be exposed and given home blood pressure monitors, and they'll be learning how to use digital apps, which help them improve their diet and lifestyle modifications. The core deliverables as well for the intervention is, for this education that we will provide on risk prevention for a repeat stroke or MI, we're really focusing on blood pressure medication adherence, really focusing on diet, salt intake, and increasing physical activity. One of our goals overall is to enhance self-efficacy of our patients, helping them figure out goal setting and making some action plans, helping them figure out what social supports they may need, and increasing their digital literacy overall. So these are just some of the added notes that we hope these patients will take away from our intervention. Just so folks get a sense of our timeline, we launched just this last year, so we're very much in the formative stages. We seek to start recruitment for patients in the fall of 2022. So for you all listening to this talk now and are here in 2022, 2023, and interested in the study, this is a great time to get involved. Please reach out. And like I said, we will seek to finish the intervention over the course of 5 years. So aiming towards finishing the intervention in 2025 and closing out the study in 2026. So we're really excited about the work that we're going to do. And here you have a sense of our timeline in case folks are interested in getting in touch. This is our study team. Like I mentioned, Dr. Amy Towfighi is leading the study. with me, and we have Monica Ayala Rivera at USC, who is the project manager, working closely with our UCN Disparities Center leadership as well. I would say an evaluation and intervention team that is made up of very diverse stakeholders, researchers, and community members from different facets and expertise, which really add a lot of richness to our study. If anybody has any questions, please reach out. I've listed my email here below, and really looking forward to potentially working with some of you all. Have a great day. Thanks.